Welcome, everyone. Thank you very much for calling in tonight to this webinar for the Australian and New Zealand Skull-Based Society. We're very lucky to have three experts in their field to talk to us on immunotherapy, which is an evolving field and certainly involves our specialty. We'll get going because I'd like to hear firstly from Associate Professor Rahul Lawda, who's a medical oncologist who works with myself and our other colleagues at PA Hospital in Brisbane. And he's done an MPhil in field of cancer imaging as well as theranostics with the University of Queensland. And certainly his interest lies in head and neck cancer involving both the head and neck, obviously, and the skull base. So thank you, Rahul. We look forward to hearing what you've got to say on this topic.
Thank you, James. Thanks for the kind invitation, and it's a pleasure to be presenting to all of you. Just checking that you can see my screen sharing right now.
Yep.
So certainly, the introduction was accurate in the sense that this is really a multidisciplinary presentation. So some of the slides would have been seen by people like James and Ben in the past, and it's absolute pleasure to present it to all of you. I really do want to talk about immune therapy and give an overview with our subsequent speakers who will build on certain aspects of the presentation with their own expertise in that field. There are my disclosures. There's going to be some case presentations here and case studies as well. So I think I'll start off with just stating the obvious that we see a lot of cutaneous squamous cell carcinoma in the head and neck multidisciplinary meeting. It is a common cancer, but 95+% of patients are cured effectively with surgery, local therapies, with multiple disciplines involved in that care. So when I'm talking about the cases that I see, it's usually the patients who have more advanced disease, have recurred despite surgery, radiotherapy, who have metastatic disease, for example. So it is sort of the tip of the iceberg in some ways, and a lot of patients are effectively managed. In the previous post study, there was a documented 17% risk of relapse at 5 years for high-risk disease despite surgery and adjuvant radiation. This was high-risk resected cutaneous SCC. And in that setting with recurrent and metastatic disease, traditionally there were poor responses to chemotherapy. So there's no doubt immune therapy has really revolutionized the way we treat this malignancy. And it's present in most multidisciplinary meetings now, with response rates being high and durable. So, I mean, we all remember the days, it wasn't that long ago when we used to see these patients come through the clinic with dermal metastases spread despite surgery, despite radiation, with limited effective treatment options, sent to the medical oncologist occasionally if there was any consideration of systemic therapy, and ultimately a poor prognosis at this stage. Previous historical treatments, and these are now historical treatments, used to use chemotherapies and monoclonal antibodies such as EGFR inhibitors, and the response rates were mild to moderate, ranging from about 10 to 30%. But more importantly, there weren't durable response rates. They shift the curve a little bit to the right, but essentially patients ultimately come back with more aggressive disease, treatment resistance, and ultimately a poor prognosis. So the change in paradigm is quite evident when you see one of the first cases that we actually had in our head and neck clinic at the Princess Alexandra Hospital. This is a patient with a left inner canthus cutaneous SCC. We discussed surgical treatment for cure. He did not have metastatic disease. The discussion involved an orbital exenteration. The patient said, is there any other option? Is there any other way I can keep my eye? He was seen by the surgeons. He was seen by the radiation doctors. And then subsequently, there was a clinical trial running using immune checkpoint inhibitor, phase 1 immune checkpoint inhibitor trial. This was several years ago now. And we popped him on the study. And obviously, anxiety is high. What we don't want is these patients to fail with systemic disease, incurable cancer, metastatic disease, especially when they start off with resectable cutaneous SCC, where we can cure these patients. And so we gave him immune checkpoint inhibitor on the study. This is him at week 3. And obviously anxiety is now rising for everyone involved, including the multidisciplinary meeting. Are we going to miss the opportunity of giving this guy a great response from a great outcome from surgery? When do you say treatment failure? Obviously our experience back then was limited in cutaneous SCC. Here he is at week 6. And what you see is marked regression there and probably just a little scab there. The question that he asked is, what's that on the inner part of my eye now? What's left behind? And it's difficult to know without sort of doing some sort of histological sampling of that area at this point in time, but he's responding, anxiety's down, and we carry on going with the immune checkpoint. That was week 6. This is him at 2 years now. So 2 years down the line, he's got continued response, no surgery, no radiation, and that tumor's regressed. So now in hindsight, you can say at week 6, he probably did have a scab there or a necrotic debris there. And he's doing very well, still able to fully see, he's got good function. Now, this is the interesting thing. This is him at 3 years now. And you might notice what I've been trying to ask the plastics doctors to do for several years now is fix his eyelid up. And so this is another change in paradigm where we got patients having durable responses at a time when we thought that we couldn't cure this patient from cancer, and therefore we wouldn't try and do any cosmetic manipulation at that point in time. Here he is 3 years later, and he's much more happier with the way his eye is functioning. And we're a lot more confident that this is probably going to be a durable response that will last a lifetime. But he's at 3 years. I think my last picture of him is at about 4 years right now. So he's doing very well off treatment with a continued response. So that was our experience. It's hard to ignore that experience when you see it in one patient, but obviously it is n equals 1 at that point in time. Here and now, subsequently, 4 years from there, 5 studies that show immune checkpoint inhibitor in the prospective setting. I want you to just cast your memory back to some of those earlier studies I showed you in chemotherapy where the sample size was around about the 30 patient mark. And look at these 100 plus patients in some of these prospective studies now with immune checkpoint inhibitors, all with very consistent messages that the response rates are present quite high at roughly around the 40 to 50% mark and durable with a quick median time to response of about 2 months roughly in some of these studies. So that's been consistent across a lot of the studies going forward. And so now we've got a lot more evidence to support us in the advanced metastatic unresectable stage. The duration of response lasts. If you respond, you're more likely to continue that response down the line at 12 months, 24 months, and up to date. So how does this look like in the multidisciplinary meeting? Well, here we go. We've got a chap with his scalp with dermal metastases all throughout his scalp. He's had a lot of treatment in the past. He's an elderly chap. He's got comorbidities, and you can imagine the patient that comes to the door. He's currently in a wheelchair over here, but he's still cognitively intact, good performance status, and able to make his own decisions in terms of treatments. We discussed surgery versus immune therapy for this chap. Now, this isn't the same patient, but this is an example of somebody who had one of the surgical operations. I've described it as a scalpectomy, but I'm sure there's a better terminology for this. And as you can see, resected disease, I think that's a beautiful outcome. And I know that's in the postoperative setting. That will actually look fantastic going on further on down the line. So I think that's a fantastic outcome. That's a surgery I would never be attempting, and neither do I wish to. This is the medical version of it. We gave him immune checkpoint inhibitor, and after 2 cycles, you can see that beautiful, clear scalp using the immune checkpoint to using the immune system to target the cancer cells and effectively eliminate them in the scalp. And what you also notice here is that you notice these slight blood vessels in the scalp, these like small capillaries, almost like there's revascularization. It's a really fantastic response to look at when you're seeing these patients respond to quite horrendous cancers to begin with. There are adverse events. I wish I could say that it's a story of just positivity, but immune checkpoint inhibitors are not without toxicity. They don't have the expected toxicities that chemotherapy does have, but essentially the immune system can target one's own body, and it's non-specific. It can occur during immune checkpoint. It can even occur after immune checkpoint is finished. Especially in a more elderly population, these side effects can be quite debilitating. And the things that we do describe often is a dermatitis and fatigue, which can affect quite a few of our patients. But colitis, hepatitis, pneumonitis are things that we often tell our patients we can affect any organ in their body, essentially. So we have seen episodes where people get endocrinopathies and even encephalitis in rarer circumstances, which are very, very difficult to manage. And usually the management involves some form of systemic corticosteroid therapy. This is the PBS criteria for Australia for reimbursement for cemiplimab. So when people ask me how can I access this drug on the government subsidy scheme, the condition must be unsuitable for curative intent surgical resection, curative intent radiotherapy, good performance status, and the sole PBS subsidized therapy for this condition. And so that's the access to cemiplimab on the PBS currently, based on the clinical studies to date. Moving immune checkpoint into the resectable setting. So this is now outside of the advanced metastatic recurrent setting. So this is resectable cutaneous SCC. There has been a couple of studies, and I don't want to go into too much detail because I know Inês is going to be covering this in a subsequent talk. But essentially 2 studies showing that immune therapy before surgery has a good pathological response rate. Pathological response rate meaning in some cases there were no cancer cells seen after up to 4 doses of immune checkpoint inhibitor. And the question then becomes, how can we predict these patients? And that I'll leave to Inês to answer. I can't do a presentation without mentioning the Descomate study. This is the pride and joy of our clinic, and this is a study looking at whether we can risk adapt subsequent management based on immune checkpoint inhibitor. And so what we did in this study is we gave neoadjuvant immune checkpoint with pembrolizumab in resectable stage 2 to 4 M0 cutaneous SCC in 27 patients. And essentially we assessed them using a clinical, radiological, including PET and a mapping biopsy assessment. If they had a complete clinical response, meaning the tumor had regressed clinically, radiologically they had a complete response, PET they had a metabolic complete response, and we then biopsied that area and could not find any cancer cells. We actually we underwent ongoing immune checkpoint inhibitor, and we avoided surgery and radiation in that group and continued to monitor them like a hawk. And in those patients who didn't have that sort of a complete clinical response, they underwent a resection, and then we looked at their pathological specimen and determined whether they needed radiation or not. In all cases, they ended up having further immune checkpoint inhibitor. It was a study involving ECOG 0 to 1 patients, non-immunocompromised patients, patients that will warrant enough high enough risk for surgery and postoperative radiotherapy. And our primary endpoint was pathological complete response, major pathological response. So that's no viable tumor cells, less than or equal to 10% viable tumor cells, or a clinical complete response. This is our first patient on the study. He had a preauricular cutaneous SCC. He has left neck adenopathy. He was suitable for surgical resection, and he underwent the Descomate study on this protocol. So after the first cycle of treatment, he had a good response. So already the pressure was off the investigators. We did a mapping biopsy at that point, which just showed necrotic skin cells, essentially. We then saw him at cycle 2, and you can see that his hearing aid is firmly placed now in his ear canal, so he can hear me. I no longer have to shout at this gentleman in the outpatient's clinic, and there's not much left to see in that area. Here he is at cycle 3, ongoing response. At baseline, you can see PET avid disease, biopsy-proven cutaneous SCC, radiological confirmation. Here he is after 4 cycles of treatment at week 12, PET complete response, radiological complete response. He underwent a mapping biopsy as per the protocol, and there was no viable tumor cells seen on that mapping biopsy. And so this gentleman underwent a period of observation with continued immune checkpoint for a full 12 months, and he didn't undergo surgery and radiation. This is the bit now that we really need to know, and this is the immature data, but this is our first patient, and at 14 months, he still doesn't have cancer in that area. So it's a positive sign, but obviously this is something now we need to look at going forward, and we'll be following these patients for up to 5 years to make sure they don't have late recurrences from their cutaneous SCC. But first patient to undergo definitive immune therapy in a resectable cutaneous SCC without having surgery and radiation. We do have more complicated cases, and these are patients who are not necessarily trial eligible. And so in these patients, they're transplant cutaneous SCCs where the risk of transplant rejection is high if we give them immune checkpoints, but obviously they also have very advanced cutaneous malignancies that can lead to significant morbidity and mortality. And in this patient, the end-to-end immune checkpoint had a fantastic response without rejection. And we have seen a couple of studies now prospectively published over the last 24 months, showing that immune checkpoint can be delivered in transplant patients, particularly renal transplant patients, with immunosuppressants given at the same time. But ultimately, it's still an area of need, and patients do succumb to their cancer quite often. I will carry on with a couple of slides in perineural spread, knowing that Luke will be covering a lot of the imaging and assessment in this, but this is a courtesy of Ben Panizza. Might be a bit outdated, so I apologize for that. But you know, as the zone increases, the risk of disease specific survival also reduces. So obviously zone 3s, can we do better for those patients with immune therapy? Zone 1s, can we do better from a morbidity perspective? Zone 2s, can we do a bit of both? And that's the question we ask with immune therapies integrated into the surgical assessment of patients with large node perineural spread. There has been a few retrospective studies, and I don't want to overlap with other people's presentations, but essentially we've published our data, and there's been quite a few recent published data, including Luke's study there at the bottom, which I'm sure he's going to speak more about, showing that response rates are quite high with perineural spread. And we've had difficulties in sometimes assessing this disease because it doesn't fall down the regular paradigm of exophytic cutaneous lesion that responds in front of your eyes. This is a patient with a right cheek SCC that responded on PET CT. Pain got better, numbness got better in his V2 distribution. But when you look at his repeat MRI, it shows that actually his V2 region looks more enhanced and thicker. Is he progressing? Have we missed the window of opportunity for surgical resection? He undergoes this surgical operation. I'm not going to pretend to educate you on what that involves. And he has a path complete response. And all you see is inflammatory cells in this specimen. And so obviously that thickness must be a reflection of the immune system in the nerve. So we're learning a lot in this circumstance, and there will be some upcoming cases to discuss that. There are discordant responses with responses in the primary and nerve in further nerve enhancement. But last two slides, I'll stop after this. Clinical recovery of perineural spread is something that I have been asked a few years back, and I said I've never seen a case, but recently I feel like I'm getting a lot more cases. This is a patient who's got perineural spread. His left nerve is his left eye is deviated inwards. We give immune checkpoint. He does have the option of quite a large surgery to remove his disease that's near his superior orbital fissure. This is him after cycle 4. He can now look out to the left. He's still got diplopia. And here he is after cycle 8. And you can see him now fixating on the left-hand side. He's got a response in that superior orbital fissure region, and he's got recovery of his cranial nerve function from perineural biopsy-proven perineural spread using immune checkpoint inhibitor. It's taken us 8 cycles to get there for this patient. And then this recent case, which always puts a smile on my face, and I'll end with this chap with facial nerve perineural spread. He had recent facial nerve perineural spread, probably within 3 months of starting his immune checkpoint, which is an important note to make here. He got to me at cycle 7 and he had no recovery. And I said to him at that point, I doubt you're going to recover now. It's been nearly 6 months. And there he is at cycle 8 smiling at me. His MRI shows consistent improvement in the auricular temporal nerve over there. And so he is a chap with facial nerve response to immune checkpoint inhibitor. So I think there's a real role for immune checkpoint inhibitor in the multidisciplinary assessment of patients. I might stop there. Thank you.
Thanks, Rahul. That was fantastic. I think in the interest of time, we're going to push on with the other speakers, and then if there's time at the end, we'll have some questions. And Inês also has to talk to Portugal shortly. So I'll introduce Associate Professor Inês Silva. She has done 2 clinical fellowships in melanoma, and she's currently a medical oncologist at the Melanoma Institute in Australia. She has a lot of expertise to show us about tumor immunology. So thank you very much, Inês.
Thank you so much. Can I just confirm that you are seeing my slides and that you can hear me? Perfect. Okay, so thank you so much for inviting me, and it's really a pleasure to be part of this webinar. And you'll see some overlap in terms of data, but it's good because I want to highlight some key points that Rahul just mentioned. And I'm going to change a bit of gears here. So I think you are already convinced that immunotherapy is very good. I'm going to highlight that again, that Rahul said. But my role now is to try to dissect a little bit more in terms of biomarkers for response to immunotherapy in cutaneous squamous cell carcinoma. And it's not that easy job because we don't have much data, but I'm going to try to synthesize to see what we have right now. So this is what I'm going to try to cover. Briefly highlight a little bit of what Rahul mentioned in terms of immunotherapy for cutaneous squamous cell carcinoma. Then general concept of biomarkers in immunotherapy, and then what can we learn to apply cutaneous squamous cell carcinoma. So again, as you know, and as Rahul mentioned just now, we use immunotherapy for patients with cutaneous squamous cell carcinoma. And the rationale for this, in fact, we have some specific rationale. So first, we know that the patients that have a long-term sun exposure and advanced age, they are at high risk of having cutaneous squamous cell carcinoma. And those two features are associated with a higher tumor mutational burden, meaning the tumor has more mutations. And that, in fact, is a marker of response to immunotherapy in general. You can see here that this is the cutaneous squamous cell carcinoma is here and is in the top ones that has a higher tumor mutational burden. Also, the fact that patients that are immunosuppressed are the ones at a higher risk of having cutaneous squamous cell carcinoma, it's another indication that we need to balance here the immune system. We need probably to activate the immune system to fight the cancer, what we do with immunotherapy. And we also know that some patients and some cutaneous squamous cell carcinoma, they have a high expression of PD-L1, as we are going to see, and this is also a marker of a better response to immunotherapy. So just two concepts. Yes, for locally advanced or metastatic disease that is not resectable, as Rahul mentioned on PBS, we are allowed to give cemiplimab, so anti-PD-1 immunotherapy. So infusion trying to stimulate the immune system to fight the cancer. And what I want to highlight and reinforce what Rahul said, this is our best treatment right now in terms of systemic treatment. The response rate is about 40 to 50%, meaning a good shrinkage. But what I would like to highlight is that only about 20% of the patients really progress despite the treatment. So we believe that about 80% of the patients, they have some benefit with this treatment, which is very important. And as also was highlighted before, the most important pattern with immunotherapy, which is different from chemotherapy, because the truth is, with chemotherapy, the response rate was not too bad. The problem was the toxicity and the short duration of response. And as you can see here, with immunotherapy, we have a plateau, meaning that patients who have a good response, they tend to be very durable. And look at the overall survival curves. They are quite high, like quite good survival curves and plateauing, which is very good. So we are curing some of those patients, we believe. But the new concept that Rahul kindly mentioned is the neoadjuvant concept. That I think everyone is aware, but just to refresh our memory, instead of, for patients who have resectable disease, so we left now the metastatic or unresectable disease, but for those patients that we can say, okay, this patient has resectable disease, the concept and the standard is surgery plus minus radiotherapy. But as we have learned from other cancers, including melanoma, what we know is that if we give immunotherapy before surgery, in fact, we activate the immune system in a different way, in a more efficacious way. And that has two main, in my opinion, benefits in terms of what we can offer to the patient. So the first thing is we can not only activate the immune system in a better way, but also we can assess the response to the treatment by looking at the surgical specimen. And we can categorize in terms of the pathological response into complete response, near complete response, partial response, and non-response. And the other thing, because I also work in the lab, so I work as a clinician, but also as a translational researcher. And I think it's very important if we want to understand biomarkers that we collect samples. And this neoadjuvant platform, in fact, allows us to collect longitudinal samples, not only of the tumor, so at baseline, a core biopsy, and on the surgical specimen at week 6 or week 12, depending on the type of neoadjuvant clinical trial, but also longitudinal blood samples that will allow us to understand a little bit more about the immune activation and if we can use that as possible biomarker. So just a little bit on that. Why are we so enthusiastic about the neoadjuvant concept? Well, this is one of the first studies presented and published by Neil Gross, where patients were treated with cemiplimab, so patients with stage 2 to 4 resectable cutaneous squamous cell carcinoma. Patients were treated with 4 doses of cemiplimab followed by surgery, and then adjuvant radiotherapy based on the risk factors. You can see here on the right the patient characteristics, and just to highlight 2 pieces of information. First, the response based on RECIST, so CT scan, and we have here objective response rate of about 68%. Again, the number of patients is not that large, but this response rate is, in fact, is higher compared to the previous studies that I mentioned. And when we look to the pathological response, if we put together the patients who have a pathological complete response and near complete, meaning patients who have 10% or less viable tumor cells in the surgical specimen after neoadjuvant treatment, which we know they tend to do very well, as I'm going to show, it's about 63%. So let's say more than 50% of the patients have a very good response to immunotherapy. But what we want to know is how will that translate into outcome? And as you can see here, this is the event-free survival curves. On the top, we have the entire cohort, and below here, we have divided by pathological response. And I guess the summary is, and we're trying to understand a bit more in melanoma and trying to translate to other skin cancers, is that if we have some type of pathological response, even if it's a partial response, patients tend to do quite well and they rarely recur, which is not true if the patient does not have a pathological response. But even in that group, it's not that everyone will recur. So we really need to understand who will do well and who will not do well, that we need to have a different approach. So just briefly on another neoadjuvant study, because I'm going to use that to explain some of the potential biomarkers. This is a study where patients were, so the same type of population, stage 1 to 4 cutaneous SCC, randomized to either nivolumab, which is an anti-PD-1, so similar to cemiplimab, versus the combination of nivolumab plus ipilimumab, which is another type of immune checkpoint inhibitor, another type of immunotherapy. But keep in mind that in the combination arm, patients had only 1 milligram per kg, very low dose in only 1 cycle. And then patients had surgery followed by adjuvant radiotherapy based on the risk factors. In this study, similar to what Rahul mentioned in the estimate study, in fact, 10 patients didn't go for surgery. 9 of them, they refused because they saw a clinical response. So what I want to highlight again is, from the 9 patients, we can see here, there were the 9 patients that had a clinical response. They are doing very well so far. And you can see here in green here, the patients that have a major pathological response, those that we know are going to do very well. So you can see here the percentage of patients, which is again between 40 to 60%. That's what the percentage that we think we are really helping patients. And here the recurrence-free survival based on the pathological response, again, if the patient has a better pathological response, tends to do better long-term in terms of event-free survival or recurrence-free survival. Now, I hope you are convinced now that immunotherapy is very important, but also to highlight 2 things. We know it can cause side effects, as Rahul mentioned. It is important to keep in mind, specifically because the population we are talking about tend to be elderly patients, frail. And the second thing is, we know, even though the response rate is quite high, is not 100%. So how can we identify patients that are going to respond versus those that won't respond? So first, I'm going to give you an overview of possible biomarkers and some of the research I have done mainly in melanoma, and then how can we apply in cutaneous SCC. So in general, when we look for biomarkers, we go from genetic testing until to gut microbiome data. So what I'm trying to say is we can go from tumor mutational burden, where we know high tumor mutational burden tends to be associated with a better response, but also if we have a better immune response, as we expect, we'll have a better response. But also the type of immune cells that in a tumor microenvironment, that matters, because if it's, I don't want to go into much detail, but for example, if we have a more activated T cells and B cells, it's good. But if you have some immunosuppressive cells, that's a bad sign. So it's not about the number and the amount, it's of quality, okay? So trying to understand the complexity of biomarkers. So biomarkers is not one molecule, can be a complex concept. So just to share some of the thoughts and the projects that we developed in melanoma that we could easily apply to cutaneous SCC. So the first one, I'm going to mention two projects. One was purely clinical. So we started with more than 600 patients with advanced melanoma treated with similar drugs that we are just explaining for cutaneous SCC. And here we utilized only clinical pathological features that we have available when the patient presents in our clinic. So patient demographics, disease characteristics, staging. So all the characteristics that we have available at our first appointment that are freely available. And then with deep statistical analysis, we try to identify the best predictive model. So putting together the best predictive features. And then we have identified a model to predict response, another model to predict progression-free survival, and another one to predict overall survival. And we have validated those models in independent cohorts from overseas cohorts. So from the predictive model, then we build something that will be practical for the clinician. So if I have a patient coming to my clinic, I would like to be able to predict if this patient is going to be likely to respond yes or no. So how does it work? So this is a nomogram, and you don't have to use that in clinic. There's an easier way that I'm going to show in a second. But the concept is those are the variables that we have identified as the most predictive variables. And if I have a patient coming to my clinic, and then if the patient is ECOG performance status of 0, I just go to this top line here that gives me the points. So I'm going to give respective points to each of the variables of the patient I have in front of me in my clinic. So for example, ECOG performance status of 0, so the patient is very well and fit, I give 17.5 points. And I do the same for each of the variables that I know are predictive. So LDH is normal in this patient, so 0 points, and so forth and so on, so on and so forth. So NLR, so neutrophil lymphocyte ratio of 9, so I'll give 17.5 points. The patient did not have lung metastases, but had liver metastases, so 0 points here. We have decided to give combination immunotherapy, and it's first line, so we give respective points. At the end, we can predict the likelihood of response, which is about 17%, going to this last line here, based on these complex statistical models to predict this response. And this is with a very good accuracy. And again, just using variables that we have freely available when we see the patients. Of course, as I promised, we have easy way. Everyone can access to the melanoma risk website, and this has other risk prediction tools. The one that I'm talking about is this immunotherapy outcomes prediction, and the idea is to press here and we can plug all the variables that are needed to predict response, progression-free survival, overall survival, and we can just press calculate and we'll have that. This is available for everyone around the world, so feel free to use. Of course, this was built for melanoma, but we are working right now in order to build this also for cutaneous squamous cell carcinoma. In parallel, we in the lab developed a more complex multi-omic model, trying to see if we should add other variables. So just to explain, we started with 92 samples from melanoma, and this is the breakdown by treatment and response. But just to explain that we went deep, we did whole genome sequencing to understand the tumor mutational burden, how many mutations the tumor has. Also the neoantigens that now everyone is talking about because of the vaccines. What about RNA sequencing in terms of gene expression, and also immunohistochemistry to see the immune infiltrate? Again, I'm not going into much detail, but just to explain, we saw that patients that had a good response, they had higher tumor mutational burden. So one potential predictor here. Also, we have seen that several, this is the responders in green here and non-responders in yellow. We have identified that the interferon gamma signature, which is a signature that represents some activation of the immune system, is the top one differential expressed between responders and non-responders, so highly expressed in responders and not so expressed in non-responders, so another predictor. But also in the tumor microenvironment, when we do immunohistochemistry, we have also seen that there is a higher percentage of patients with high T cell infiltrate, so immune cells infiltrate in the good responders, and also a higher percentage of patients with a high expression of PD-L1 in the good responders compared to the poor responders, so other potential markers. And again, we analyzed more than 50 possible markers. Then we put everything together to identify what are really the key features. And what we have identified is that the combination of tumor mutational burden, so the number of mutations that the tumor has, which again, as I said, could be a consequence of the sun exposure, for example, and also the interferon gamma signature, which is a signal of immune activation. This is the best way to predict response. And we validated that. But what we really want is to put things together. So we want to put clinical data, gene signatures, genomic data, the tumor immune infiltrate, to really put things together and be very, very accurate in terms of saying, yes, this patient is going to respond, this patient is not going to respond. And in fact, right now, we have this personalized immunotherapy platform that was built for melanoma, but we are currently testing all our cutaneous squamous cell carcinoma patients. So the idea is to really, really apply to our patients and be able to live to really discuss those reports that we'll have at the end in our multidisciplinary team meeting to really say, okay, this patient is likelihood to respond to our standard treatment. And if not, what can we offer the patient? And learn from this. So this is a platform to learn in terms of biology, why some patients don't respond. So this is happening right now. So very, very exciting. Okay, what exactly do we know? So this was in mainly melanoma, and we're trying to apply to cutaneous SCC. But what do we exactly know? What is the data we know for cutaneous SCC? Does it make sense to apply what we know in melanoma to cutaneous SCC? And the answer is yes, because the small data we have, in fact, goes in the same direction. So, for example, tumor mutational burden, in the Neil Gross study, the neoadjuvant study, they have looked into the tumor mutational burden, and they have seen a higher mean and median tumor mutational burden within patients that respond compared to those that do not respond. Also, they looked at the PD-L1 expression, and you can see that there is a higher percentage of patients that achieve a pathological complete response in the patients that have a PD-L1 high compared to PD-L1 negative. So yes, those features are associated with response. But of course, we need to put them together to really get the accuracy. So in the same study, they also they did nanostring to look to the tumor microenvironment. And again, they saw a more immune activated tumor microenvironment in the patient that responded here in red compared to the non-responders. And those are just like key immune cells that are important for the response to immunotherapy. In the study that I just mentioned, the neoadjuvant study that had the combination, I include this study because I think they added a very interesting concept. So here they didn't see much difference in terms of tumor mutational burden, but they saw interesting differences in terms of the immune activation, in terms of interferon gamma signature, similar to what we saw in melanoma. But what I would like to highlight is the concept of a dynamic biomarker. And for example, Rahul mentioned that in his study, they used a PET scan, and they used PET scan also to evaluate response. So it seems that if we could really predict response, and sometimes we don't need to go for surgery, as Rahul was mentioning, because as you can see here, PET scan was very good predictor of a good response. So that's something to keep in mind and to include in our daily practice. And I couldn't really not mention this study by Rahul. And again, Rahul is, of course, here, so he could probably add more information. But I just want to explain that it's very important, these kind of studies where we do multiplex immunohistochemistry, so several markers. So we could really understand what is happening. And it's going to be very hard to say, okay, this is a responder, this is a non-responder completely accurately. But it's important to understand the complexity. Because within the resistant patients, there are patients that are immunosuppressed versus non-immunosuppressed, depending on also the site of disease. But I just want to highlight the complexity of the research that has been done, and so important to understand a little bit better of the biology behind. So, in conclusion, 3 concepts. Yes, we can apply what we know for other cancers in terms of biomarkers for immunotherapy to cutaneous SCC, and we have some of them already with ticks in terms of interferon gamma, tumor mutational burden. But what we really have to do is to try to put everything together, to really come up with a very simplified version and say, okay, when we put everything together, we need this marker and this marker. That's it. But in order to get there, we are really going to continue adding and recruiting patients with cutaneous SCC to this personalized immunotherapy platform, and trying to discuss those patients and trying to learn more about biology and biomarkers. And then just one last thing about the concept of biomarker. Biomarker does not need to be a static biomarker at baseline. Can be a dynamic biomarker. If our question is, does this patient have a good response or a good response enough that to avoid surgery in the neoadjuvant context, probably a dynamic biomarker is more informative. So thank you so much for your attention and time.
Thanks, Inês. Thank you so much. That was amazing. And it was very interesting to see where this is going to go in the future. I'll introduce Luke now, Luke Mclean. He's a medical oncologist at the Melanoma Institute. Sorry, he's at the Peter Mac, I should say. And he's also been doing a lot of research with biomarkers and also some work on perineural spread, which for us is part of our clinical practice. So thank you so much, Luke, for continuing the discussion. Luke, are you there?
No worries, just getting the mute going. So hi everyone. So I'm Luke Mclean, medical oncologist at Peter Mac and St Vincent's. So as I said, I'll be talking about assessing perineural spread in cutaneous squamous cell carcinoma, and hopefully that flows on nicely with some of the discussions we've had thus far. So perineural spread is the radiological descriptor for the process of macroscopic tumor invasion into named nerves. And whilst relatively uncommon, it does feature in cutaneous SCC, where it can cause significant morbidity due to involvement of the head and neck region, as we've seen in some of the cases that have been discussed already. Historically, PNS has been associated with poorer treatment outcomes, and there's also a lack of consensus on how to best manage locally advanced cutaneous SCC when there is perineural involvement, with treatment consisting of aggressive surgical resections or radiotherapy with or without chemo, and they often cause much debate in the MDM. So measuring PNS, well, there's no prospectively validated approach for assessing PNS response to immunotherapy, and patients with PNS alone have RECIST 1.1 non-measurable disease and thus have been excluded from the key clinical trials of immunotherapy. Understanding whether a PNS response to immunotherapy can be seen on conventional imaging techniques is of clinical relevance in cutaneous SCC, in clarifying disease status, assessing overall treatment response, and aiding choice of surveillance imaging modality in PNS predominant disease. And I think in terms of imaging techniques, there's probably no question that MRI is the gold standard of care here. It's an excellent tool that allows superior soft tissue contrast enhancement and multiplanar imaging, which allows us to look at the skull base. And the contrast enhancement on MRI can reflect a disrupted blood-nerve barrier in PNS, and you can use fat suppression to enhance the assessment of the tumor-infiltrated nerves. But I think it's also important to mention FDG PET here as well, as there's a growing role, as you've already heard, for PET in assessing response to immunotherapy in advanced cutaneous SCC. but there are likely some obvious limitations in using PET in patients who might have PNS predominant disease. And so there's little in the literature. Rahul's mentioned a few of the series that exist looking at assessing PNS and cutaneous SCC treated with immunotherapy. But I wanted to just share this particular study, which was published in Laryngoscope in 2021, as they did try to utilize a criteria to follow PNS response. And they reviewed the outcomes of 11 patients treated with immunotherapy for cutaneous SCC with clinical PNI of large named nerves. And the primary endpoints were clinical response, so looking at improvements in neuropathic pain, hyperesthesia, nerve weakness, decrease in visible tumour, and an assessment of the perineural invasion by 2 neuroradiologists. And with a median follow-up of around 13 months, they identified that 8 cases demonstrated improvement on MRI, and 1 had stable disease, suggesting that responses in PNS could be captured. However, only 1 case had a complete response, and thus they hypothesized that perhaps the post-treatment appearance of affected nerves seemed unlikely to return to normal. And for interest's sake, they did also report that there were 7 clinical responses in those 11 cases. But overall, we have limited literature on measuring PNS response to immunotherapy, and many questions remain, including can we measure and follow PNS on conventional imaging? Does PNS change or return to normal with immunotherapy? And is there any utility of FDG PET given its expanding use in advanced cutaneous SCC? And so at PeterMac, we have recently also published our clinical experience in this space earlier this year. And the rationale for this retrospective project was to explore some of those remaining questions. So can we follow PNS over time? And could we develop some response assessment criteria to enable this? And then anecdotally in our MDM, we'd also seen that in a number of cases that there were cases where we had complete remission of the PNS with immunotherapy. And that hadn't really been reported in the literature before. So we wanted to investigate that. So this was a single center retrospective review. It recruited patients with advanced cutaneous SCC. So that's metastatic disease or locally advanced disease that was not amenable to curative surgery or radiotherapy. And they all had to have baseline PNS and were treated with immunotherapy. The primary outcome was blinded PNS assessments, so at 3 defined time points, so less than 5 months after starting, 5 to 10 months, and then greater than 10 months. And we also had some secondary outcomes looking at correlation with RECIST assessments on CT and MRI and assessment of PNS on FDG PET. And out of 141 cases, there were 20 patients who met the inclusion criteria. And this is the radiological criteria that was developed in conjunction with the radiology team. So the experience of the radiologist was that PNS is usually visualized on MRI as an abnormally thicker nerve with increasing enhancement, but not exclusively. So some PNS is visualized as thickened or mass-like nerve with minimal or no enhancement. And so this assessment criteria was designed in a way to try and encompass those features, and a grading system was chosen to be in line with the RECIST 1.1 terminology, which is what we use on CT and MRI in clinical trials. And also in line with the RECIST methodology, all assessments were compared to a baseline MRI at each time point. And so of those 20 cases, the average age was 75.7 years. Most patients were male, in keeping with the demographic that often gets this malignancy. And most patients were treated with cemiplimab, which is the most commonly used immunotherapy drug in Australia. It's the PBS reimbursed immunotherapy drug for cutaneous SCC. Just for interest's sake, I've highlighted that 3 of these patients actually had perineural disease only, so they had no measurable mass. So this group of patients have been excluded from clinical trials in the past, and purely by coincidence, all patients had locally advanced disease. And so now this is a swimmer's plot of the responses seen per patient at each of the differing time points. And with a median follow-up of 18 months, 70% of cases achieved a response by 5 months. Once again suggesting that a PNS response could be captured on imaging. And of the 14 cases that achieved a PR in that initial time point, 7 went on to achieve a complete response and 8 in the total cohort by the end of the study period. There was also a second blinded radiology review demonstrating a 94% concordance rate. And so this figure demonstrates some of the characteristic MRI changes in PNS that can be seen in some of these patients. So in this case, for example, the arrow in the top panel indicates a thickened and enhancing right maxillary division trigeminal nerve at baseline, and then at that less than 5 month time point where there was a diminished size and enhancement and further improvement there in image C. And then the bottom panel is just highlighting that what we see in the PNS is often concordant with what we see in the RECIST measurable mass, with that lesion also improving at each of the same time points. Now, there's been increased interest in the use of PET for assessing depth of response to immunotherapy in cutaneous SCC. And this is largely due to reports of increased discordance between RECIST assessments on CT and MRI and PERSIST assessments on FDG PET imaging, where it's been hypothesized that, as in other tumors, notably melanoma, many of those stable long-term RECIST PR, stable disease masses that don't change, if you actually do a PET scan, they demonstrate a complete metabolic response. And thus the hypothesis is that PET may be a better marker of depth of response. And it was based in part on these initial observations that prospective serial FDG PET CT scans were incorporated into a subsequent cohort on the Regeneron cemiplimab studies. And just in the last few weeks, those findings have been published in JITC, and they found that FDG PET had comparable sensitivity to conventional imaging in detecting responses, but it did detect a greater percentage of complete responses. And given the increased utilization of FDG PET as an imaging modality in cutaneous SCC, we did think it was important to look at and understand FDG PET's limitations in PNS. And in this particular series, there were 14 patients that had a baseline PET, so we could do a PERSIST measurable disease assessment. And I'm sure it's to no one's surprise that none of these original FDG PET reports suggested the presence of PNI. We did still get a nuclear medicine blinded review of all 14 cases, but the three main reasons FDG PET did not raise suspicion of PNS was that the FDG avidity in adjacent brain obscured the PNS, it was below resolution of FDG PET CT, or it just did not demonstrate avidity. However, I did want to show this case because I thought it was an interesting case. It's slightly against those theories, as it was this patient's PET scan that was shown in our MDM that actually then prompted us to do an MRI scan confirming the PNS. So perhaps a different way to the usual, I guess, presentation or a series of these images. But this patient had a very large right facial cutaneous SCC with extensive perineural spread. And you can see in that first picture, we've got the MRI scan showing thickening of the right infraorbital nerve in the right pterygopalatine fossa, right infraorbital fissure, and right infraorbital canal. And this was concordant with the curvilinear FDG avidity on the FDG PET CT. And so I guess in some rare cases, when you're armed with the anatomical knowledge of where named nerves are located, when FDG avidity is demonstrated in that curvilinear kind of pattern at nerve locations, or even at anatomical bone sites widened by PNS, such as the pterygopalatine fossa, it could be suggestive of perineural involvement. But more often than not, it's like this particular case, where you have PNS involving the left V1. You can see thickening in the left supraorbital nerve in the axial image A, with some enhancement there on image B, and then a similar picture in the coronal slice in image D, but this was not detected on FDG PET. And so whilst in some cases FDG PET may raise suspicion of PNS, it's certainly not designed to measure or follow this, which is an important consideration for oncologists when we're following these patients if they have PNS predominant disease, and following that is of clinical importance. The other thing I wanted to touch on was pseudoprogression, and Rahul showed some cases that had a flavour of this before, but pseudoprogression is thought to occur in less than 10% of cases, and in this cohort it occurred in 15% of patients. All three cases had an enhancement and increase in size of their PNS and their RECIST assessments as well, so a concordant response, which is often what we see. But I also just wanted to remind everyone of the two definitions or broad definitions of pseudoprogression. There are firstly the defined criteria that have been developed for clinical trial use, such as the IR RECIST criteria, where if progressive disease is identified on a scan, it then requires confirmation of that disease progression 4 to 6 weeks later, and that's thought to capture most cases of pseudoprogression. But the reality is not all patients fit into that particular category and timeline. And there are case reports and series of responses well outside of this time frame, which is where the phrasing delayed responses really crept in. So now I wanted to show you a couple of cases. And so this is a case of a 65-year-old female who saw us at Peter Mac with a large left supraorbital cutaneous SCC. She had an MRI, demonstrated she had a 40-millimeter lesion. She had thickening and enhancement of the left supraorbital nerve. And so we discussed her in our multidisciplinary meeting. And the recommendation was for an orbital exenteration and adjuvant radiotherapy, which the patient declined for morbidity reasons, and she saw us to pursue immunotherapy. Post-commencement of immunotherapy, that lesion became larger, causing a left-sided ptosis. And after a further dose, she eventually consented to craniofacial surgery due to concerns of progression. However, during skin preparation in theatre, the lesion actually fell off, and thus surgery was delayed to permit pathological assessment. And histopathology demonstrated necrotic tissue with no viable tumour consistent with a complete pathological response. There are also features of inflamed tissue, so some granulation tissue and changes thought to support an overall picture of pseudoprogression. In another case, I had a 68-year-old female who presented with a primary cheek cutaneous SCC that had been resected 2 years prior and then returned to the clinic with a painful recurrent lesion of the right maxilla that was extending along the right infraorbital nerve. The multidisciplinary recommendation was for surgery. However, she declined and proceeded to cemiplimab due to morbidity reasons and concerns. After 4 cycles of immunotherapy, the lesion, however, was noted to be rapidly enlarging, and we proceeded to an FNA, which was non-specific as it often is. We did an MRI scan. It demonstrated the lesion had increased in size, so from 41 millimeters to 52. There were multifocal areas of progression, and there's extension to the anterior maxillary wall. And so this is just the MRI images for this particular case. You can see the primary cutaneous SCC lesion has increased its size, extending to the anterior maxillary wall, shown by the green arrow, and there was also persisting PNS in the right infraorbital nerve. Despite multiple imaging modalities and an FNA, we couldn't exclude progression. She had worsening paresthesia along the upper lip and increasing pressure sensations. So she proceeded to surgery. However, on her histopathology assessment, they identified extensive tumour regression. She had characterised by extensive residual keratin. There was no viable tumour seen in the maxilla, the maxillary sinus, or the orbital contents, and she only had a small residual viable tumour focused deep in the soft tissue that was completely excised. And then in this particular case, I wanted to present an example of a delayed response. Now, I don't think these cases are as uncommon as we think. I have quite a few of, this is a very unique scenario, but we have quite a few patients that have certainly not fitted into the characteristic criteria set out, like IR resist for pseudoprogression. So I think it's really important to be aware of these cases as well. So this was an 81-year-old male who presented with an advanced left supraorbital cutaneous SCC. He had an MRI that demonstrated perineural disease affecting the left trigeminal nerve as far back as the cisternal segment. So that's his MRI picture there. After 2 cycles of immunotherapy, he developed ataxia and was admitted post a fall. He had an MRI that showed progression of his disease with an enlarged mass-like change in the left trigeminal nerve with increased enhancement at the left pons and Meckel's cave. After much debate, treatment was continued because after his admission, he started to feel a little bit better and his symptoms were improving. However, a response on imaging was not immediate, and it certainly didn't fit the IR resist criteria for pseudoprogression. He was continued with immunotherapy, and it wasn't actually until the 10-month time point that we were able to identify quite a dramatic resolution of the left pons mass as well as thickening and enhancement of the left trigeminal nerve, as you can see here. So figure C is that 10-month time point. So the left pons mass had resolved and so had that enhancement and thickening of the nerve. So I think to summarize, there is potential to measure and follow PNES responses to immunotherapy, which would benefit from validation in a prospective study, particularly given isolated PNES recurrence is not an uncommon scenario for us to deal with in the MDM. And I think as oncologists, we often feel a little bit uncomfortable about giving treatment to non-measurable disease where it's difficult to assess a patient's response. PNES responses are likely best captured using criteria that encompasses nerve enhancement and thickness on MRI. And it's likely that over time, perineural changes could resolve and return to normal, i.e. patients could have a complete response in their perineural disease. But perhaps one of the biggest limitations is that experienced head and neck radiologists are best placed to measure these changes. And even when we did our series, we used the two radiologists that demonstrated the really high concordance rate were both head and neck radiologists. And pseudoprogression and delayed responses are really important issues in measuring PNS responses in cutaneous SCC, as they are for measuring resist disease on CT MRI and persist assessments on FDG PET. That's it.
Great. Thanks so much, Luke. Very interesting to see those MR changes. We've gone a little bit over time. We've got to have the annual meeting, but Richard, anyone want to make any questions or comments just apart from me to say thank you to our speakers for this evening?
Yeah, great talks. Really important, I think, for surgeons and radiation oncologists to understand some of the things that we spoke about tonight. Well done. Really important.
James, could I just ask one question?
Sure.
I think Inês has left, has she?
Yeah, she had to talk to Portugal.
Okay, so maybe Luke can help us. One of the things in skull-based surgery we have problems with is with sinonasal melanoma, and the results are atrocious, and surgery has almost no role to play. So could Luke give us given that Inês is from the Melanoma Institute, I was interested to see what she would say. But Luke, could you give us your thoughts on mucosal sinonasal melanoma and how we should be thinking about treating it?
Yeah, I can, and I'd be interested to see what Rahul thinks or what he does in his practice as well. But sinonasal melanoma is extremely difficult to treat. We don't see the same immunotherapy responses that we see in cutaneous melanoma. It's not a particular tumor group where I would be giving immunotherapy to try and get a dramatic upfront response. So the response rates are much less in around the sort of 20 to 30%, I think, in most cases. And so in my practice, quite often we'd be giving a bit of ipi-nivo and then trying to actually chuck in a little bit of radiation on top. But it's certainly not the curative scenario that we have in cutaneous SCC and melanoma. I know, Rahul, do you do anything in particular for these rarer cases?
No, I mean, I don't treat a lot of melanomas, but ipi-nivo is one of those scenarios where you give the combination immune checkpoint to try and get a response. It's traditionally resistant to monotherapy here.
Yeah, single agent really doesn't have any role in mucosal melanoma, and yeah, I like to add in radiation. I think that's kind of been our practice at Peter Mac if we can. Quite often unless they have distant metastatic disease.
Thanks.
I just had one question for Rahul. That was to talk about duration of immunotherapy. How long are we meant to, if patients get a complete response, when do you stop therapy? Or if patients get a partial response, how long do you keep therapy going for?
Yeah, it's a good question, James. The PBS allows us to have up to 2 years of treatment on immune checkpoint, but quite a few of the studies had a clause in it suggesting that if you had a complete response and you maintained that complete response for X duration, subsequent scans, etc., then there's a potential to come off the treatment. I certainly find that if we've had a complete response and we've taken patients off for a complete response, actually that's a durable complete response, and patients don't seem to progress off treatment. And again, I think we just have to get predictors of it. So like Luke had said, and with the sometimes you don't always see a complete response using CT, but I find that PET seems to predict responses a little bit. Complete metabolic responses seem to predict a better long-term outcome And certainly what we're also finding is that as we do further and further imaging as time goes on, we seem to be developing more complete responses, which means I think oncologists are more comfortable calling it complete response when you're 12 months down the line.
Yeah, okay, great. Thanks very much. Richard, I might hand over to you now.
Yeah, no, thanks very much. I'm going to